Okay, so in a nutshell, what we've talked about here, sympathetic and parasympathetics. Sympathetics, right, dilate your pupils. Parasympathetics, constrict them. Sympathetics, dry in your eyes, nose, mouth, wet in your eyes, nose, and mouth. Um, Bronchodilation in the lungs and an increase in respiratory rate. Beta 2 is the adrenergic receptor responsible for that. And we all know that adrenaline is there, or epinephrine is uh, the neurotransmitter. Um, and an increase in heart rate and increased inotropic effect. Beta 1 is responsible for that. You got a decrease in your digestion, right? And over here, you got the opposite of all of those things. A decrease in digestion, increase in digestion, um, an increase in blood sugar, right? And that happens in the liver, right? And over here, it doesn't necessarily decrease your blood sugar, but it stops the increase. So no increase in blood sugar. So I just put that there. And it's something that I didn't mention yet in the lecture was adrenaline, or the adrenal gland releases epinephrine. So when you get this response, you're scared from the bear, a message goes to the adrenal gland to release epinephrine, right? And epinephrine is going to travel via the bloodstream all over the body and help these things happen all over the body, right? So as a hormone, it's being released from the adrenal gland. It's going to go all over and stimulate these effects as a neurotransmitter is happening in the synapses, right, and carrying out nerve impulse transfer. Let's see. So your adrenal glands, so decrease in urine, or the alpha-1 receptor is responsible for that. And I wrote sphincter in there because it's responsible for the sphincter part. It's some of the betas, beta 2 and 3, I think, are responsible for relaxing the detressor muscle. But as far as increasing the sphincter tone, it's the alpha-1's receptor sites, adrenergic, alpha-1 adrenergic receptors. Vasoconstriction, and those are also alpha-1s. So skin and the skin capillary, so that increases. So if you are a person who is constantly under stress, right, chronic stress, and you have an alpha-1 blocker, it may cause vasoconstriction or vasodilation, right? Because whenever you give a blocker, right, and the right way to say that is not an alpha-1 blocker. The right way to say that is an alpha-1 adrenergic receptor antagonist, right? But everybody calls it an alpha-1 blocker. So know both. Know what's correct because you're going to see that in the tests, and know what you're going to hear out on the floor while you're working in clinical situations. So increased sweating is another thing that happens under the SNS. So decreased sweating over here in the PNS dilates your skin caps. So you just see that you got the opposite effects over here in the parasympathetic nervous system. And I usually put PSNS for parasympathetic nervous system, but a lot of people will, but just put PNS. I like to put the whole thing because you don't want to mix it up with the peripheral nervous system. So now I'm going to talk about a couple of medicines just to kind of give you an idea of things that we take, right, that affect the sympathetic nervous system. You can see one of the reasons that I think that this is an important lecture. So let's talk about medicines that manipulate this system. Beta adrenergic antagonists, right? Everybody on the floor will call them beta blockers. That's what you're going to hear them called, beta blockers. If you say, is that a beta adrenergic antagonist, the nurse will probably look at you like, no, it's a beta blocker. You know what I mean? Because that's what people call them. So, know both, because you'll see one on the test, you'll hear one on the floor. So, the beta blockers, I think I mentioned them a little bit. Now, in order to get this video, hopefully you've watched the other ones, because you're going to need to. You should watch the other ones on the autonomic nervous system. Beta adrenergic antagonists, beta blockers. If let's say, now they're beta 1 blockers, by the way, right? Beta 1, heart, right? Increases your heart rate. So beta 1 antagonists. might see them called just beta 1 antagonists, beta antagonists. Might see them called beta 1 adrenergic antagonists. You might see them called beta blockers. I mean, you know, they're all the same thing. And you can figure out what it is just by what they're saying. You know, think about what they're saying, what the word is. So beta 1 antagonist, what is that going to do? When we're talking about these medicines, let me get back up just a little bit here. We're talking about antagonists and agonists, right? Agonists stimulate the receptor, antagonists block the receptor, right? So you come up here, right? You got this this receptor here, and you got this neurotransmitter coming in here, right? And it comes in here and it fits in there, and boom, it stimulates this guy here, and now this guy's all stimulated, right? It's been stimulated. So, so that's what an agonist does too, right? It does the same thing that the epinephrine did. The epinephrine comes in here, right? There's my epinephrine, and it comes in here, and now it stimulates this guy. Now this guy here is all stimulated, right? It's doing whatever the hell it's doing, depending on what organ we're talking about. So now, let's say you give an agonist. It's going to do the same thing the epinephrine did. It's going to come in here and it's going to stimulate it, right? Boom. So if you're stimulating beta 1s, you would get more heart rate and all that stuff, right? Increase in heart rate and stuff like that. Usually we're talking about beta 1 antagonists, right? So they're blocking beta 1. So what happens there is you got this medicine here, right? Here's your beta 1 blocker medicine. Here's your receptor. And instead of fitting in there like that, it kind of comes in here and it just and it fits into one of these slots. And it doesn't stimulate it, right? It's not stimulating this. It's just fitting in there. So it doesn't stimulate it. What does it do? Well, it blocks it. Because with that thing stuck in there, when the adrenaline comes along or epinephrine comes along, it can't fit into there because you got this thing stuck in there, right? So you're blocking it. You're blocking that receptor's ability to stimulate or to carry on an impulse to an effective organ or to get the effect that you want to get. So that's what the blockers do. So when you give a beta blocker, beta 1 blocker, it's coming in here, and you're going to get, instead of the increase, you're blocking this effect, the adrenergic effect, with the beta 1 blocker. So you're blocking a lot of those receptors. And so instead of getting the increase in heart rate and the increased inotropic effect, you're going to get a negative inotropic effect and a decreased heart rate. So people on beta blockers are going to have a slower heart rate and their heart's not beating as hard. People with tachyarrhythmias, tachy means fast, arrhythmias means out of rhythm. A is without, right? So fast tachyarrhythmia is an arrhythmia of your heart where your heart is beating fast and not in rhythm, not in the right bump, 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 bump. That's in rhythm. Bump, 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 bump. That's not in rhythm, right? So you've got a tachyarrhythmia or a tachydysrhythmia, right? It's not doing what it's supposed to do. A beta blocker is usually pretty good for that, right? Because it'll slow it down. A lot of times it will pick up its rhythm then, right? It slows it down. So that's one thing beta blockers are used for. But the main thing they're used for is to decrease your blood pressure, because it's slowing your heart rate and making it so your heart isn't beating so hard. So that's decreasing your cardiac output. It's decreasing your blood pressure, right? So these are blood pressure medicines, but they're used under certain circumstances where they're going to work best, especially if your blood pressure and you're a person who has chronic stress. It's going to work pretty good because chronic stress has been stimulating that beta 1, and so now you can block that beta 1. And what's beautiful about this is it's blocking only the beta 1. And they call that selectivity, right? Now, if you are giving a beta blocker that is non-selective, that would mean that it blocks all the betas, right? All your beta receptors. It's not blocking only the beta 1s, which means that and they're out there. The first beta blockers were all non-selective, so they would block the beta 1, so you would get a decrease in your heart rate, and the heart is beating not as hard. But it would also, you get bronchodilation from that, so you're decreasing the sympathetic tone on your bronchodilation, so you're going to end up with bronchoconstriction. So when you would give these, you would have to be very careful, because normally when you get a person who comes in and you're giving them a beta blocker because you want to slow down their heart rate and put it in rhythm, you do not want to cause bronchoconstriction. But unfortunately, with a non-selective, you kind of cause them both at the same time, because it's blocking all of the betas. Now, if you have a beta 1 selective antagonist, that's would be a lot safer. Now, if you're giving this medicine to somebody with asthma, you definitely don't want to give a non-selective. And even the selectives, everybody's a little different, right? There's minor differences between these receptors. They're all adrenergic receptors, and the differences are very small, and we're all different. So it is not going to be this, they're not going to have the same amount of selectivity from person to person. And the higher the dose is, if you give them a low dose, the higher the dose is, the less selective they are. When you start giving a lot of these beta, they're supposed to be beta 1 selective, but you're giving pretty high doses, they're going to start affecting your beta 2s, right? So selectivity, it varies from person to person. That's an important thing to know. And I'm going to give you an example of that. You got a guy who's got asthma. You don't want to give them something that's going to cause bronchoconstriction, because that's what asthma is they get a reactive airway that constricts when it doesn't need to constrict from allergens or whatever, and now you're causing this thing to spasm and for no reason. You don't want to do that in somebody with asthma. So somebody's got asthma, and doctor really wants to give them a beta 1 antagonist. So he wants to give them a beta blocker, so he'll pick them. Of course, he's going to pick a selective one, and he's going to give them a subtherapeutic dose. Subtherapeutic means below is sub, therapy, below therapy dose, right? So in other words, it's a dose that is not going to have an effect. So they're giving it down here, subtherapeutic, and they will slowly increase that dose over a few weeks. And watch this person and try to hit this sweet spot where they can get some decrease in heart rate and anatropy, and maybe regulate an arrhythmia, and not get the bronchoconstriction, right? So that's what happens when you're dealing with people. So now let's move on down the line here. I want to talk about beta agonists. These are things that stimulate betas, right? Well, you can get beta 2 agonists, right? Same thing, and they're not very selective either. But so you're trying to stimulate the sympathetics and your betas, right? With an agonist, it's going to stimulate it. And what is it going to do to the lungs? A beta 2 agonist, it's going to, the sympathetics cause bronchodilation, right? So you give an agonist, it's going to stimulate that bronchodilation. We're not talking blocking now. We were talking blocking on the other one. This one's not a blocker. So it stimulates. It's going to enhance the effect of the adrenergic receptor. So, or stimulate the effect of the adrenergic receptor. So we're going to stimulate this guy, and we're going to get bronchodilation. So who you give that to? You give that to a person with asthma, right? They're coming in with an asthma attack or dyspnea from some reason. Dyspnea means a difficulty breathing. So you're going to give them this beta agonist in hopes to open up those bronchi. The big one, albuterol, right? It comes in a syrup, and it comes in handheld nebulizer medication. See that a lot in handheld nebulizers, right? That's the big one that they give. The puffers, right? Somebody's got asthma, they will have this. It's like you start getting wheezing, breathe that down in there, it goes right into where it needs to where it needs its effect, and it will hopefully go in there and hit those receptors and cause bronchodilation. And then the person can breathe, right? So that's what happens there with albuterol, right? It's beta 2 agonist. And it's not real selective. Anybody who's been on albuterol, or I shouldn't say anybody, some people say it doesn't bother them at all, doesn't make them jittery, right? But most people, I will go ahead and say, most people that have been on albuterol know that it makes them jittery, right? So part of the fight or flight is getting jittery, right? Getting everything ready to go because you got to run from that bear. It makes them jittery, makes their heart race, right? Because they're getting all of these beta, they're getting the other beta things too, right? They're getting an increase in heart rate, and heart is beating harder and faster, and they're feeling jittery, and they're taking this, they're breathing better, but boy, they feel like crap, and they really don't care for it. So that is one of the problems that you have there with albuterol. Now, another thing is there's Xopenex out there. Now, years ago, when Xopenex came out, they claimed to have a higher degree of selectivity. In fact, they claimed to be very, very selective for beta 2, whereas albuterol was not as selective. So it was out there. Boy, it came out, everybody wanted to use Xopenex because they thought, wow, we're not going to get all these side effects. Well, they found out that with the increase in cost, they decided that most doctors kind of went back to albuterol, and Xopenex isn't being used like as much as what we thought it was going to end up being used, because it doesn't quite have that selectivity. Well, it does have the selectivity, I'm pretty sure, but I just know that it's not being used as much because when you use, because using albuterol is still pretty darn safe. The docs give it to people who can handle it. They try to give the right dose so that they don't overdo the broncho or the heart and the other beta 1 problems, and by stimulating the whole sympathetic nervous system. So by doing this, they can cut the costs and they can still give the albuterol. Although I know a lot of doctors who will go ahead and they go with Xopenex if the person has some kind of a cardiac history, because they don't want to increase that heart rate if they don't need to. Don't need to increase the workload of the heart for no reason. If it's increasing for a reason, that's different, but not, it don't want it to be increasing just because we're giving a medicine that increases it. Now there's also, we've been talking over here in the beta, so we've been talking about manipulating the sympathetic side. When we're talking about breathing, there's a medicine out there. I've talked about albuterol and Xopenex, right? And I've talked about beta blockers, which, by the way, beta blockers that we give, big one is metoprolol. Metoprolol, right? That guy there is given a lot of times. It'll slow down the heart. It'll decrease the amount of oxygen consumption by the heart, slow it down, right? It kind of gives the heart a chance to kind of be like it's in a relaxing mode. So metoprolol is a real big one. There's also atenolol and carvedilol, but they end in LOL. That's the big thing. Beta blockers end in LOL. Now, when we're talking about over here beta agonists, we're talking about albuterol. These guys end in this ROL very often. Now I'm going to talk about another medicine, ipratropium, I-P-R-O, I don't know if I'm spelling this right, but ipratropium, right? And this guy here is an anticholinergic. So it's going to cut down, it's going to block acetylcholine activity. And by doing that, you come down here by blocking acetylcholine activity. Acetylcholine is part of the parasympathetic nervous system, and it causes bronchoconstriction, decreased heart rate. So by blocking that, you can get bronchodilation and an increased heart rate. So you're getting kind of the same symptoms, or the same effect. So you're getting the same effect with this. We're actually getting the same effect by blocking the acetylcholine over here is what we were with the albuterol when we were agonizing, stimulating the sympathetics, right? So you've got this here, you're blocking the parasympathetics. Over here you were stimulating the sympathetics. You end up with bronchodilation in both of those cases. Then there's a medicine out there, Duonab, where they actually have both medicines in it, and they give it in a handheld nebulizer. Works wonderful. People will start breathing real fast because you're using two different mechanisms to accomplish bronchodilation. Okay, let's come on down here. Increase blood sugar. So, you know, this, no, I'm not going to get into that. Urine, okay, decrease urine output down here, right? So when you got somebody who has urinary retention, a real common medicine is an alpha-1 blocker, tamsulosin. I was just on it because I had kidney stones. She wanted me to flush them out, so let's increase your urination to try to get those kidney stones flushed out. I'm just getting over it. I still feel like crap on it. So you go tamsulosin, Tamsulosin, right? So you take tamsulosin, and tamsulosin is an alpha-1 blocker, which alpha-1, if you remember right, it increases the sphincter tone of the urinary sphincter, urinary bladder sphincter. So by blocking that effect, you decrease the tone of that sphincter, so you can pee easier, right? And you'll pee more, right? You get more urination at one time. And it worked for me. It helped me flush out the kidney stone. So let's see. So that's tamsulosin. A lot of times, a person with BPH, benign prostatic hyperplasia, they will be on tamsulosin. Very often it helps, and we'll talk about that when we talk about BPH. So that's just a few medicines that I talk about. Now I want to talk about one over here specifically on the parasympathetic side, and that is when we give, and that is atropine. Atropine. And the reason I want to talk about atropine is because you'll see it in several different medicines. It kind of does some different things. Atropine it blocks a lot of the acetylcholine, so it has a lot of effects. And acetylcholine, so when I'm talking up here at the top, you're looking at this pupil constriction, right? So atropine is in a lot of eye medicines to cause pupil dilation, right? Used to be the big one that the docs put in there, but it has a longer half-life, so that they use something else now, and I'm not into that, so I don't know what it is they're using now. But it's probably a variation of atropine, something else that will block the cholinergics, but it has a shorter half-life, so you're not having to wear this patch over your eyes for 12 hours or whatever. So anyway, and wetting. So wetting your eyes, nose, and mouth. So if you have a runny nose and you're sick, so you're going to find anticholinergics in a lot of different cold medicines. But anyway, that was, now let's get back to atropine, because those are different anticholinergic medicines. But atropine, you will give that, when a person has diarrhea, when you get that, your antidiarrheal, if you look at see what's in it, you'll see that atropine is in it. Very often atropine will be in it. Why do they put atropine in antidiarrheal? Well, because it's the main effect of atropine is what will give you the antidiarrhea effect. It slows down the gastric digestion, right? It slows down the peristalsis, slows down everything to it. It slows down your juices, it slows everything down so that everything doesn't just shoot through your intestinal system so fast. So that's a big part of what atropine does. And now, like I was saying before, there are several anticholinergics that we'll talk about in different videos. But for now, I'm just going to say that these anticholinergics, the class of anticholinergics, will very often be used as cold medicine, because a lot of the misery that you're in when the cold is from this nasal and increase in flushing, right? The increase in tearing in your eyes and all that stuff. So you can cut down on that by giving these medicines. Okay, so that's it for these videos, and hopefully they help you understand the autonomic nervous system. And I've talked just about a few medicines, just a couple of medicines here, but it is endless. I swear there's an infinite amount of medicines out there that manipulate the parasympathetic and sympathetic systems, right? Anytime you see one of these, just another one off the top of my head, in a cold medicine, a lot of times you'll see pseudoephedrine, right? And that there is mimicking epinephrine, right? As it made in the laboratory mimics that, so it'll mimic those responses. So what are you going to do when you mimic epinephrine, right? You're going to get drying eyes, nose, and mouth. So another thing. So instead of the anticholinergic over here in the parasympathetic side, you're going to be manipulating the sympathetic side. But both of them are going to hopefully give you a drying effect. The pseudoephedrine is not as available as what it once was, and you got to sign for it and stuff, and you can only buy so much and things like that because of drug use, right? Well, think about it. If you get this sympathetic, think about everything it does. If you are artificially stimulating the sympathetics out there, you're getting all this energy and shakiness, and you're getting all these effects that some people I guess like. So I wouldn't. I want the opposite, things to slow me down. But so anyway, that's where we're at, and it goes on forever. The importance of this is it will help you with pharmacology and understanding all of many different medications that will be talked about. Also help you understand the effects of illness and trauma on a person. So this is an important class to start with. I think it's a good thing to look at and to know pretty well before you get going into nursing. In fact, any med-surg class that I teach, I will teach this on the first day. Thanks.